Hey, good evening, everyone, and thank you for tuning into this webinar. We're here tonight to talk a little bit about advanced technician roles. My name is Ryan Whistler. I work with the Johns Hopkins Community Pharmacies with the specialty team, specifically with solid organ transplant recipients. And I have Nicole and Daphne here with me who will also be presenting. So I'll go ahead and let them introduce themselves. Daphne, if you want to go first.
Sure. Good evening. My name is Daphne Robinson. I am currently the pharmacy operations manager at MedStar, working in the outpatient pharmacy.
Good evening. My name is Nicole Bryant. I am the Director of Operations for MedStar Outpatient Pharmacies. We currently have 6 pharmacies that we service the Baltimore and Washington area.
All right, great. So we'll just go ahead and jump in. So we're going to talk about 3 or 4 different technician opportunities, and then I guess we don't have anybody online, so any questions, but we'll make sure to post our contact information in case anyone that's viewing this at a future time wants to get in contact with any of us about questions about anything we talk about tonight. Okay, so I'll lead off here. So the first position I wanted to talk about of the 2 I'll do is the technician supervisor. And so in our outpatient pharmacy at Johns Hopkins, this is also called a pharmacy business manager. So essentially, each one of our locations within the outpatient pharmacies has this business manager, which is the direct supervisor for the technicians, and then they report to the clinical pharmacist manager at each of our locations. And so they do a lot for us. They're really the leader of the technician team. So I've just picked out a couple key points that I see them doing. So the first thing is really the interviewing and hiring process. And obviously this is a team effort, but they're involved in the creation of creation and updating of screening rubrics. So before we even get a candidate in that's potentially going to work with us as a technician, we'll have them, answer a set of questions, talk about their experience. And we really want to set that up so that we're being fair for all the candidates, so that we're screening them equally. They're kind of getting the same questions. So we're bringing in, candidates based on objective information. And then we also want to make sure that we have similar questions that we're asking them, so that they each kind of have their own same opportunity to display their skills for us and have that opportunity to come in as a candidate. And then once we've selected those candidates for interviews, we'll of course bring them in. Generally, we're going to have them on site, but sometimes that's done remotely based on our availability and the availability of the interviewee. And so that really does take a lot of effort, even for our technicians here. We're generally having them see like multiple groups of people. So that takes an arrangement, some scheduling from both the staffing perspective. So, the people that are already working there that are interviewing the person, we need to make sure that we find good times throughout the day for them to be participating in the interview, but then also that the candidate can be there, and that those things kind of run back to back. So, we wouldn't have a situation where a candidate shows up and there's nobody there to interview them, or we're maybe doing one interview and then we have an hour break and then another interview for the candidate. That's just not really a good presentation for them. So it does sometimes take a lot of coordination and a lot of outlook and calendar skills to make sure that that interview process runs smoothly. And then, of course, hopefully we have a successful candidate or candidates, and we're going to make interviews to them. So that pharmacy business manager or technician supervisor is also involved in the position offers. So, deciding who we're going to offer that position to, and then also, how much do we want to offer to that position. If they're making counter offers, are we going to accept that, or are we going to reoffer that person? And then kind of that last piece of that hiring process would be the kind of more HR aspect, where we're having to screen them. So they might have to do a drug test that you'd have to arrange. Might have to make sure that they, don't have any specific infectious diseases like tuberculosis. TB is one that we generally have to screen for in a healthcare setting to make sure they're not a risk to themselves or to patients. And then we also have, kind of once they're on board, the extension of the human resources side. So, of course, if you're in any position right now, you're probably going through regular reviews with your supervisor. Usually that happens every 6 months or a year. You might also have more or less formal, rather, meetings in between. So, for us, we generally meet like every month or every 2 months with our manager, just kind of as a check-in to see how things are going along the way. Part of that review process is generally, of course, hopefully we're getting raises every year or so. So that's also, part of discussion. Generally, you'll have some sort of like rating process set up by your employer that you'll go through with each of your direct reports to kind of tell them how they're doing, and then correspondingly, like whether they're, how much of a raise or what raise they're going to get that year. Time off planning is another big thing. So I think, for us at Hopkins and probably for my colleagues here, we've got pretty big groups of direct reports. So, you're not just dealing with one or two people and trying to figure out time off, but you're probably dealing with, for our positions, 5, 10, 15 people at a time that you're trying to plan, help them plan time off, make sure that they get their vacations, but also that make sure that you can have business continuity. You don't want to have, 5 people working for you and 3 people off. That probably is a recipe for a not successful day. So you want to make sure you kind of spread out that PTO as fairly as possible. And of course, that comes with another, point is how you do that. How do you make sure that people are getting paid time off on a fair amount? Is it first come, first serve? Are you going to do it by seniority? You just really have to make sure that you have some process in place that everybody knows about, so that there's really no hard feelings when people, maybe get their request denied. They understand why that is, or like how to get their request treated as a priority. And then kind of last thing to talk about here is, the unfortunate part when people really aren't performing up to their expectations. Our business managers and really all supervisors are obviously a part of that, probably really the first line in terms of doing any sort of performance corrections. So, our recommendation is generally to pull people to the side if you have some kind of individual feedback. You don't want to do that in front of people, but if there's a pattern where you see that a lot of people are making the same mistakes, then that's like something that you'd bring to a staff meeting or something of that nature, where you're telling people, hey, we see this pattern developing, and we just want to make sure that you all know the expectations moving forward. So again, still on technician supervisor, so still got more to talk about here. So kind of moving away from the HR management to like the daily workflow. Again, our business managers, our technician supervisors are really critical here. So when we do have those call outs, when people call out sick, or their children are sick, or there's some kind of family emergency, like, we need to have a contingency plan for that, obviously. Sometimes that means with working with less people. You might have 4 people there, and now you have to work with 3 people. Does that mean you're going to jump in, or does that mean you're going to try to pull from, maybe some other site? Like for us here at Hopkins, we have, several locations on this campus where, maybe we could pull from somebody else if they have, more coverage than we do. Throughout the day, we're obviously needing to cover technician breaks. So generally, if you're working an 8-hour day, you probably know you get usually 2 15-minute breaks and then a half-hour lunch break. So obviously, as those people are working out of workflow and coming back into workflow, you need to have a plan to manage that, make sure all your stations are covered, make sure all your workflow processes are being done and are not getting backed up when people are out of workflow. And like I mentioned before, you need to probably work kind of across the aisle with other locations, and make sure that if they have staff that you can borrow, that you can get them over there. So making sure you're on the flip side, giving them your staff when you can, because it's kind of a give and take. You can't always be a giver or a taker. It's got to be a balance for sure. And then lastly, the last kind of aspect I wanted to highlight with the technician supervisor is their role in the budgeting request. So having worked here for a long time, I know the first answer is very rarely that we're going to hire more staff. So certainly that is something that we need to do from time to time when business calls, but very much more frequently for all the people who are managing it. And I see Nicole shaking her head that we want to figure out how can we be more efficient. Does that mean, again, moving people from one location that's slower to another location that's more busy? Does that mean that we're going to implement some remote services so people can be doing data entry or other workflow tasks remotely, and they're not really having to answer for the phones and dealing with dealing with the public more or less? They're able to kind of just focus on one specific task and kind of just do that, and then maybe more efficient than kind of jumping from one task to the next. We also talk about a lot about expanding services. So particularly being part of a health system, we're getting requests all the time from prescribers and social workers and other healthcare team members, providers, about how can we serve our patients better as a health system. And so we definitely want to be an integrated part of that. So does that mean that there's some group of patients that needs special service. For example, here at the Hopkins, we have an international patient program where people are coming from other countries. They don't speak the language. They're not familiar with the U.S. healthcare system, and they generally don't have U.S. insurance. So that, is like a completely different patient from what you're typically dealing with if you're like a retail pharmacy or community pharmacy. So like, what can we do to serve those patients better? If they're not comfortable coming up to the counter, like how can we get their medications to them? If they don't speak English, how can we make sure that we have an interpreter there available for them at kind of a moment's notice? So, things like that we want to keep in mind and make sure that we're serving our patients as best we can. And then lastly, kind of another unfun thing is, dealing with replacement equipment. So our business managers, our supervisors do a lot of that. So, simple things like, do we order, like we need to make sure we have enough printer paper. Do we have, scales? Do we have scanners? When computer equipment breaks down, do we know who to go to have that? Do we have enough backup equipment, readily available? We're not waiting days and days for equipment to be here. So again, that can be a group effort, but a lot of times those are things that fall to our technician supervisors as part of that team to address. So the other technician position I wanted to highlight is the clinical pharmacy technician. So I think this is kind of a newer role. It's really a newer role probably across the pharmacy spectrum, where we're getting more into the specialty disease space. So that's where we use our clinical technicians. And so for those of you that may have not heard or be familiar with that term specialty in the past, that really deals with a couple of categories of medications. It can be things that are, really expensive medications, could be several $1,000s per month or even more than that. Could be things that are maybe, difficult to administer. So particularly like injectable medications, a lot of like subcutaneous under the skin injections might have like really unique ways that they're administered, unique devices, or maybe inhalers that are kind of different to use. That are going to put patients at higher risk for potentially using the medication incorrectly. Or it can be a combination of those things. So, there's really no like one definition for specialty, but those are a couple things that I've seen that, that can kind of qualify those medications to be a specialty medication. So they just basically need, more attention. We need to spend more time on them to make sure that patients are using them correctly. And so because those medications, can be used incorrectly, they're at a higher risk, or because they're more expensive, we want to make sure patients are taking them. Obviously, we want patients to take every medication, but when you're talking about, a tablet of lisinopril or atorvastatin that patients just have to take once a day, that's, relatively easy to do, whereas some of these specialty medications are much more difficult to take and to keep up with. They might have a unique dosing schedule, things of that nature. So, we want to make sure that patients are taking their medications. We want to review their prescription records. Sometimes we do proactive refill calls. So, they're getting their medication every month. We're going to call them a week in advance to check to see, hey, are you really down to your last week's supply of medications? If not, what's going on? That might be something that you can answer as a technician, or, that might be a point that you want to pull in a pharmacist if it seems like the patient's being non-adherent to their medications. And then a lot of these medications, because they are expensive, a lot of insurance plans want them to be filled via a pharmacy, a specialty pharmacy that's generally like owned, at least in full or in part, by the insurance plan. So like, CVS Caremark has CVS Specialty Pharmacy, Express Scripts and Medco have Accredo Pharmacy. So a lot of these high dollar medications, they'll want to go through there. But some of you might have experience with dealing with these external pharmacies. They're not always the easiest to deal with. They are, they're a call center. They're not a person to face in front of you. Can be very impersonal. I'm not trying to put them down, but that's the truth. It can be very impersonal. It can be very hard to get a hold of them. It can be difficult to coordinate your medications through the mail. So, that can be a role for a clinical technician to make sure that our patients understand that process and are getting their medications in a timely fashion. Kind of going back again, I keep harping on this, but this high cost. So these medications, in addition to all things I've mentioned, might require what's called a prior authorization. And that term really just means that the insurance is requiring additional information before they're going to pay for the claim. So, they want to make sure that the patient is using it for the right conditions. They want to make sure that the dose is appropriate for the condition that's being used. Just more information than what we can submit via a normal pharmacy claim. And usually that means that the doctor is going to have to, doctor or doctor's representative is going to have to be having a role in that. So we'll try to help along with that process. We might have like separate software to do that. We have a web platform that we use to help manage that, and other pharmacies might have other ways that they help manage the prior authorization process, but kind of the more that we can do to remove barriers to getting medications for a patient, we're going to be better served by that. Sometimes though, we cannot get those authorizations. We kind of tried and exhausted all options. We just can't get what the prescriber intended. And so there might be information in the claim that we can provide to the doctor. We might have an active discussion with the doctor about, this medication isn't covered. Do you want us to check if these medications are covered? We can run what's called a test claim, basically a fake prescription to see, what's covered and how much is that going to cost. That's really, I can say from experience, that's really appreciated by the providers, where they're not having to kind of like write a prescription and go through that whole process for every prescription that they write. We can just have a direct conversation with them and say, like, here's what's covered. Do you want to try this, or not? Kind of how do we want to move forward from that? And I think the rest of this I kind of already covered here, the last 2 bullet points. So the last slide I have here is also on the clinical pharmacy technician. So again, high dollar medications, they need assistance with covering these medications. And sometimes even when they're covered after we've done the prior authorization, they still might be too expensive. And so depending on the type of insurance that the patient has, they may be eligible for either a coupon card, a copay card, which is, I think most people are kind of familiar. You can just kind of go out to the manufacturer's website, kind of sign up for that yourself, or even sign up for that for your patient. But then there's also these things called patient assistance programs, which are a little bit more involved. They generally require a patient to provide documentation of income. So these are really meant for people with generally lower income levels, and it's usually based on a certain multiple, the federal poverty line. Each individual program is a little bit different in terms of their qualifications, but it's generally going to be income based. They might also be required to spend a certain amount of their income per year on medications before they're eligible for these programs. But the good news is that if you can get these patients enrolled in these programs, get through all the paperwork, generally these assistance programs are going to provide medications to the patient for free, which is, kind of the best outcome that you can have for a patient. Again, it can take a little bit of logistics. The patient assistance programs applications are pretty long. They're gonna, it can be 3 or 4 pages long, and they're gonna require the income documentation. So, helping that patient, reminding that patient, getting that information to the provider are all things that our clinical pharmacy technicians do to make sure that we are able to get patients enrolled in those programs, and again, get them access to medication. And then last thing I'll touch on here is the collection of laboratory data. So for a lot of these medications, there's either a recommendation or a requirement that we monitor prescription data. So for example, for medications that we use to treat a lot of inflammatory conditions, we want to make sure that patients are not at risk for tuberculosis. So they might have to get tuberculosis screenings in advance. Or during their therapy. They might have to get like hepatitis B vaccination before they should start the medication. So those are just a couple examples, but there's a lot of different ones out there that we maybe need to collect that data before the patient starts on the medication as a requirement for coverage, or we need to make sure that we're monitoring that lab information to make sure that the medication is being safe and efficacious for the patient. And so with that, I'm going to turn it over to Daphne to talk about, oh, sorry, I forgot I had one more group here. I'm talking about the inventory specialist. I apologize. I forgot I had another slide. I'll turn it over to Daphne in just a minute. So the inventory specialists are another role that we have, and a lot of different pharmacies have. So one of the things that they do is to maintain the robotic dispensing machines. I'm not sure other names here at Hopkins. The ones that we have are called Paradas, if you're familiar with that. And so there's a lot of maintenance that goes into those. I mean, they are nice when they work, but they don't always work well, and they require constant maintenance. So the first thing that you really have to think about is what medications are you going to put in there. So generally, these machines are only going to accept things like tablets and capsules. They're not going to be able to pour liquids in there. Injectable things that are odd sizes, unit dose packages. Really not probably appropriate for these machines in most cases. And you also want to make sure that you're choosing items that are going to be helpful to your team, right? So you don't want to have probably the medication that's dispensed once a month in this machine. That's not really, not really going to be helpful. You want the machine to be dispensing things that you're dispensing 20 and 25 times a day, so that automation is really giving you a benefit. Those machines also require supplies. So for Parada, it's things like a cell, which is basically the plastic box that you put the medication in to help the machine dispense. So those things wear out every so often. So you have to make sure that you have those on order. If you're changing what medications you're putting in there, you're usually using a new cell to do that. So Those are the sorts of supplies that you need to put in there, in addition to like vials and bottles that you probably find throughout your pharmacy. Our technicians in the inventory space also help us kind of make sure that our products are harmonized. And by that, I mean that we're using like the same NDC. So, you probably know if you worked in pharmacy that, lisinopril or atorvastatin, they might have, 15 different NDCs. We found it's really helpful to try to have all of our pharmacies order the same NDCs so that if we need to borrow, when we're trying to borrow, we don't have, one store has one NDC of lisinopril and we have the other NDC of lisinopril, and we really can't use that to fulfill an order. We try to make sure that we're all ordering the same thing. So there's ways that you can kind of set that up within your dispensing system to say like every store is going to order the same NDC. Another big thing that our inventory team does is to monitor our acquisition costs. So I don't know about you guys, but our wholesalers do not tell us, they're not very open about when prices are going up or down. So, if you keep ordering the same NDC, you might see that you're paying, twice what you were, and there's another NDC out there that's half of as expensive. So it's nice to have someone on the inventory space to monitor that, to say, this medication is less expensive. Let's start ordering this, because your reimbursement is generally going to be the same for every tablet of lisinopril 5 milligram you get. Where your benefit is how cheaply can you get that? So what's the margin in between what you buy it for and what you can sell it for? There's also medications out there that are limited access. So generally these are going to be drop ship items, things that might only be in like one wholesaler's distribution center. So like a wholesaler might have 6 or 7 distribution centers across the United States. They might only stock a certain product in one distribution center. So generally that's just going to take longer to get to you. A lot of times those products are also non-returnable. So you want to make sure that when you're ordering those products, you're going to actually use those products, because once they're yours, they're yours. Then just kind of the day-to-day inventory spot checks. So we do things like cycle counts is a kind of common term for this. So just looking at high volume medications, making sure that the number that it says you have in the system is the right number on the shelf. This also might be applicable to high dollar medications, because we kind of get more bang for your buck if you're looking at high dollar medications, and making sure that you have the right amount of them on your shelf. Also looking at what your par levels are. In other words, like what is your minimum level of medication? How much do you generally want to keep on a shelf? Is that 1 bottle, 2 bottles, 10 bottles, depending on how much volume you have, and is that still appropriate? Want to be constantly going back and monitoring that and make sure that your the amount on your shelf is correct for what you're dispensing. And then of course the really unfun activity in my mind is the full inventories. So depending on how big your pharmacy is, this may be more or less of a pain, but I know most pharmacies probably have several thousand different NDCs on their shelves. So this is generally an hours-long process involving most or all of your staff. But we do need to schedule those things. They're regulatory requirements. So the Board of Pharmacy requires, I believe in Maryland, to have you do a full inventory. I think it's every 2 years, but most stores do it more often than that. I think we do it every 6 months here. You can save yourself a lot of trouble, we found, by doing pre-counting. So kind of as you're getting close to inventory, assigning people like sections to do, or like as you're counting the tablets out of a bottle, just kind of writing the back count on that, even though usually you might only do that for controlled medications. That's a helpful thing that our inventory team implements for us. And then also reviewing the results for accuracy. So I think we all know that things are labeled different ways. Your Lovenox, is it by syringes or by mLs? Are you using a bottle or a tablet? Those sorts of information. You just want to make sure that people have entered their inventory counts correctly. All right, so I think I'm actually to Daphne's section now. I'll go ahead and let her take over.
Thank you, Ryan. So I'm going to talk about the bedside delivery technician position. And I will say I'm very biased. I really do love this position. It's one of our positions that's on our growing career ladder here at the outpatient pharmacy for MedStar. I'll talk a little bit about it because I get so excited when I talk about bedside. So this technician actually has to have at least 3 years of pharmacy experience. They must have their PTCB or their EXCPT. This person is dedicated to our Meds to Beds program. So here at MedStar on the outpatient side, we have 6 of our pharmacies, our outpatient pharmacies, where they do have this program. And the Meds to Beds program is where our pharmacy tech works very closely with our inpatient team, and they work on getting the discharge prescriptions for our discharge patients. That way, our patients won't have to make another stop before going home. They're able to get all of their prescriptions before they leave, and also any education going along with those prescriptions. This person is also the face of our pharmacy. I always like to say that this person kind of is a marketing kind of person, because they are the face and they are on the units representing the outpatient pharmacy. They also act as a liaison for our pharmacy, getting involved in the various meetings that they have on the units. So whether if that's rounds, they have IMOC rounds, which are the interdisciplinary rounds in the hospital where your doctors, case management, the dietary team, occupational therapy, physical therapy, that whole team is discussing patients and what their plan for care is after discharge or during their care at the hospital. So they're attending those staff meetings, those huddles, and they're working very closely with them. So they are also not only part of our outpatient pharmacy team, but they're part of our bigger team up on our inpatient units. They also promote the utilization of the program, so they are marketing for that service. They're going into patients' rooms, talking to patients, letting them know that we can fill their prescriptions before they're discharged. Also letting them know about the convenience of getting their prescriptions before they leave the hospital. And a lot of times when our bedside techs talk about bedside in that manner, patients automatically want to get their prescriptions filled, because what they are thinking is that when they're discharged, they just want to go home and rest. So that bedside tech is kind of like they are engaging on the front end before the patient is being discharged, and they're kind of building that relationship with the patient both during their care. The bedside tech also does a lot of the education. So when they're going to rounds, they're identifying which patients are good candidates for our bedside program. So patients that are their plan of care is going to like an assisted living facility or a group home, those would not be, I guess, good candidates for the program, because those those facilities, they actually utilize our long-term care pharmacies to get patients' prescriptions filled. So we also have that bedside tech talk about the benefits of the program, and a lot of it is the accessibility. So being able to get those medications that may be hard to find in a local retail pharmacy, getting those filled, and also anything that may be a high dollar amount. Maybe a specialty drug. We have the advantage because of our relationship and affiliation with the hospital, we're able to get some of those medications that your other retail pharmacies can't get. They also talk about bridging the gap for getting those prescriptions. So if a patient is getting a prescription and it needs prior authorization, that bedside tech is working very closely with our doctors, hospitalists, residents on getting those medications changed, or working with our case management team to help with that prior auth process. In the event that a patient cannot pay for their prescriptions or can't afford them, that technician is also invoking case management to get them to cover those prescriptions. Because at the end of the day, we want to make sure our patients leave with everything that they're supposed to have. That way they don't come back to our facilities. They also participate in our hospital-wide new residents orientation. So when the bedside techs go to those meetings, they're pretty much explaining the purpose of the program, talking about how bedside, how that correlates with the HCAP scores, which the HCAP scores are part of what the hospital is graded on. And in particular, the scores of medication adherence and compliance. So the bedside tech is talking about that. They're talking about how easy it is to be able to get their prescriptions filled with us. Because if there are issues, the tech is working very closely with the doctor because they're on the unit with them. So if there's any questions, if there may be a prescription that is written incorrectly, that bedside tech is at the right side of the doctor, being able to clarify those things and being able to get the doctor to rewrite those prescriptions. That way our patients can leave with the right prescriptions and that they're taking them correctly. Next slide. Also, a lot of the relationship building. So I will say that with this position, it is a great networking opportunity. It allows for the bedside tech to be involved in the different departments within the hospital. So not only are they part of the outpatient pharmacy team, they're working with our hospitalists, they're working with the residents, they're working with case management. And sometimes not all together, but depending on what the needs of the patient, they're meeting with them separately to be able to take care of the patient in whatever form is needed. That bedside tech is also working closely with the patients, gathering their information. So the electronic health records that we do use, sometimes we don't have insurance information for the patient, or their pharmacy benefit information is not in the system. So that tech is actually getting that information from the patient, confirming if the patient doesn't have their card, finding out where that patient fills their prescriptions, and then calling to get that information from that pharmacy. They're also, when they're talking to the patient, they're finding out if the patient has money. At that point, if the patient says that they don't have money, or they don't have a family member that is able to assist them with paying for their copays, that bedside tech is then working with the case management team to see what they can do, to see if there are any resources, to see if they're able to cover the medications. Are they able to provide any kind of coupons and things like that? And the bedside tech is also looking at those things. I will say Eliquis is a very hot item in our pharmacy, where a lot of the doctors do send that over for DBT. And if the insurance is not covering it, and typically for like our ortho patients, patients will just get a month supply of that. The bedside techs do have resources, and they do have coupons and access to coupons where that patient can get that medication free for the first month. So it is a win-win for the patient. They leave with the medication, and then they don't have to pay for it. Pretty awesome. And also, the bedside tech is also working on various committees in the hospital. So I will say, once upon a time when I was a bedside tech, I worked very closely with our orthopedics patient experience team to work with them as far as what the discharge process is, and to figure out ways that we can improve the service and how we can work better with our different stakeholders in the hospital to improve that discharge process. Because pharmacy is just one part of the discharge process. You have other factors, which include like physical therapy. Patient actually has to pass physical therapy before they are discharged. Case management may have to work closely to get, I guess, rooms or placement for the patient after they are discharged. So it's a lot of things that happen within that time frame. So that tech being involved and being connected on those different committees in the hospital and those different teams really does help unify that whole patient experience, and making sure that that care process is pretty much streamlined. Going to move this over to Nicole, and she'll talk about the Director of Operations position.
We've heard so much. Like, I'm super excited about the different positions that technicians can utilize for their own personal career ladder. I will say, starting off as a weekend technician many, many years ago, I never thought that I would be sitting in the position that I am sitting in now. Being the Director of Operations, I am required to have my PTCB as well as my state license. I am required to have a MBA. So I have an MBA and I have a Master's in Healthcare Administration. And I am required to have a minimum of 10 years of management experience to sit in this position. However, my day-to-day daily operations definitely starts off with operational functionality, meaning how do I get my stores open? How do we get them up and running? What does the daily workflow look like? So I have a team of operations managers underneath of me that are usually on the phones no later than 5:30, 6 o'clock in the morning, sending out text messages and emails to myself and others to keep us abreast as to what is going on as far as callouts and other items that will affect our day-to-day workflow. So my job is to, again, direct the workflow patterns of our different pharmacies. I am also over training processes in our pharmacies. So when we have new hires, my team, we develop the policies, the processes for all new hires. We make sure that we are setting goals and metrics for the pharmacy teams. We are making sure that we're educating on those goals and metrics. I get to sit in meetings with the COOs and the CFOs of our MedStar hospitals and go over budgets and staffing for each one of our sites. I get to review many spreadsheets and many emails about staffing and how we can improve staffing. What do we need to do to improve staffing? I go over a lot of budgets and analyze and figure out how much money we do have to work with and how we can utilize that money by bringing on resources to help support the teams. I also have to do reviews and provide feedback for our pharmacies. Probably a couple of years ago, maybe 2 or 3 years ago, we actually implemented a new pharmacy system. That was probably a 5-year vetting process in which we went to different pharmacy systems and actually looked at their systems, looked at how much it would cost the system as a whole, what would be our financial return, all of the things that you would do when you are budgeting for a new system. So we were able to implement this system, get it up and running in 10 of our MedStar outpatient pharmacies, and just making it a smooth transaction for our patients and our employees. Next slide, Ryan, please. Another portion of my day is human resources. I feel like I do this the majority of the day. However, I get to hang out with our directors of HR and come up with our career ladders, come up with our pay rates and pay scales with compensation. I get to sit on different meetings and different participate in different activities around onboarding and training and new associates and how we interview and how we do the process of recruiting, how we reach out to the pharmacy students at the different schools, and how do we get MedStar a part of being preceptors for the pharmacist and technician programs. So those are the cool things that I get to do. Not only do I get to have the resource of MedStar in all of their HR departments, I also get to meet people at like Fortis for the pharmacy technician training programs or Allstate, and set up those different affiliations with the pharmacy technician schools. Or we may go to a Shenandoah or University of Maryland and meet with the pharmacists to be and have them have us talk about how great it is to work at MedStar and offer them our pharmacy student positions that we have here at MedStar. So that is pretty cool in my position. And we also get to participate in community-based hiring events. So I get to go to different events in the community, like Harbor, for instance. We had a community-based hiring event there that I was privileged to go to. We had one at our Franklin Square location in the community, and one at our Union Memorial in the community there. So I get to do fun things like that. Next slide, please. Marketing and growth. So I think this is the hardest part of my job, is actually identifying new businesses, new growth opportunities for our pharmacies. Although we are in each hospital, the majority of our business does come from the hospital. Our hospitals are located in communities. So our goal is to ensure that not only are we taking care of the patients that are coming into our hospitals, but we're offering support to the communities. So I'm always looking for the next event or the next avenue of how we can help in our different communities in the areas that surround our hospitals. I do participate in multidisciplinary quality and service improvement teams within the hospital, and that's looking at different metrics and, again, analyzing patients' surveys and their engagement and how we can better service our patients. Again, I collaborate with, I feel like the hospital as a whole, from the EVS manager down to the nurse secretaries that are on our units, to our, again, CEOs and CFOs to ensure that the pharmacy is offering the best care and service to our patients. Collaborating with other healthcare systems. We are here with Ryan again at Hopkins. We have other entities like LifeBridge. We collaborate with University of Maryland. So it's not like we're working in a silo here in pharmacy. I always say pharmacy world is super small. And when you blink your eye and you open them again, somebody you will know who knows somebody is in pharmacy. So it is a big collaboration within the healthcare systems to ensure that we do come up with working relationships to ensure that if things need to be shared across systems, we are able to do that. And then engaging with National Pharmacy Association and continuing education. MedStar has a pharmacy technician training program here that I am one of the founders for. So just working with the PTCB and the EXCPT and ensuring that we have programs and a pipeline that persons who want to pursue their PTCB and pursue that EXCPT, they have that outlet to do so. And then giving them the resources to do so. So that is my day-to-day in a nutshell. Fun times sometimes, hard work all the time, but it is very rewarding and very fulfilling.
All right. Well, thanks, Daphne and Nicole. So yeah, I just wanted to quickly summarize, kind of the different roles that you heard about today. So heard a lot about operations, administration, HR. Of course, technicians can be in direct patient care. I mean, if you work in a retail pharmacy, that's really where you're at. But there's a lot more to it than just the filling and talking to people at the register, as you've heard of all of us talk about today. And then, yeah, the technicians are, I spoke a little bit about it, but they're just like super integral to inventory management. I don't know what we'd do without our technicians. I definitely don't have time to do all the things that I need to do without the technicians. So, if you work in a pharmacy, the technicians generally outnumber the pharmacists by two, three, or four times. So that just tells you how important you guys are here. So hopefully you got a lot out of this presentation and piqued your interest in some of the different roles that are out there. And just want to highlight, particularly for the things that I talked about, I'll let Daphne or Nicole chime in if they want to, but a lot of the roles that I talked about, here at Hopkins, they don't require official advanced training. So I know both of them, they have MBAs and they're in, seems like pretty high management roles, but, for our inventory specialists, our clinical technicians, those are things that you can kind of move into just by experience for the most part. So just don't want anyone to be scared away and think that, you have to have formal training for every one of these positions. Definitely, there's a lot of these things that you can do, just by experience and with the skills that you probably have, but you may not be thinking about already. So again, I know we don't have anyone here on the call with us live to ask questions, but again, as I mentioned earlier, when we post this with MSHP, we'll post our contact information so that if anyone is viewing this at a future time, please feel free to reach out to any or all of us about any questions that you have about these roles or other roles or career advice. I'm sure we'd all be happy to give that to you. So again, thank you all for whoever's listening, and have a good night.